Welcome to this Pearl of Laboratory Medicine, brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls, as well as other free educational material at traineecouncil.org.
Hello, my name is Laura Connelly-Smith. I am an assistant professor in hematology and the assistant medical director in apheresis and cellular therapy at the University of Washington Medical Center and Seattle Cancer Care Alliance. Welcome to this Pearl of Laboratory Medicine on peripheral blood stem cell collection. The purpose of peripheral blood stem cell collection is for the acquisition of hematopoietic stem or progenitor cells for the purpose of transplantation. Hematopoietic progenitor cells, or HPCs, are responsible for the formation of blood cells. This presentation will cover the why, how, and when peripheral blood stem cell collections are performed. HPC transplantation is a widely accepted treatment strategy for most hematological malignancies and for several non-hematological malignancies and non-malignant conditions. In several conditions, HPC transplantation is recognized as the standard of care, with well-defined clinical evidence available in the form of high-quality clinical trials and/or observational studies. HPCT includes autologous and allogeneic transplantation. In autologous transplantation, reinfusion of the patient's own stem cells allows for the timely recovery of the bone marrow following the provision of high-dose therapy. Chemotherapy can be associated with significant toxicity, but regimens do not include immunosuppression. The aim of allogeneic HPC transplantation is to replace a diseased or non-functioning marrow with normal bone marrow from a healthy, related or unrelated donor, such that the patients acquire a new immune system. Patients receive conditioning with chemotherapy and/or radiotherapy, and regimens contain immunosuppression to prevent rejection of the new graft, as well as to prevent graft versus host disease, also known as GVHD. In allogeneic transplantation, it is the healthy donor that undergoes the HPC collection. The CD34 antigen is a clinical important molecule expressed on the surface of and serves as a marker of the cell population containing HPCs. HPCs are a subset of CD34 positive cells. At steady state, CD34 positive HPCs are rare in the peripheral circulation, constituting about 0.1% of circulating mononuclear cells. Their number is 10 to 100 times greater in the bone marrow. Studies have confirmed that CD34 positive cells are mobilized into the peripheral blood and, when collected for transplantation, are similar to marrow-derived cells in their ability to fully reconstitute hematopoiesis after myeloablative conditioning. A minimum threshold of HPCs for transplantation has not been identified, although 2 times 10 to the 6th CD34 positive cells per kilogram is generally accepted as the minimum goal. With lower doses, there is increased risk of delayed or failed engraftment. Several studies have shown that higher doses of CD34 positive cell infusions are associated with faster engraftment. There is some concern in allogeneic transplantation that sufficiently higher doses may be associated with GVHD. A target CD34 positive cell dose between 4 and 5 times 10 to the 6 CD34 cells per kilogram is deemed to be ideal based on available data. HPCs can be collected by different methods. Apheresis is a technique by which cells are removed by a machine from the blood. Following mobilization, the individual is connected to the apheresis machine by peripheral or central catheterization. Blood is removed from the body and separated by centrifugation. The buffer coat containing the HPCs is removed, while the remainder of the blood is returned to the patient. Bone marrow harvest involves multiple aspirations from the posterior superior iliac crests, usually in the OR setting. A total of up to 20 milliliters per kilogram donor weight can be removed. Umbilical cord blood is performed by gravity using a bag system after term delivery, with umbilical vein puncture with placenta in or ex utero. The preferred source of progenitor cells depend on donor availability, treatment, or clinical trial protocol and patient preference. So what are the differences in peripheral blood and bone marrow collections? Randomized trials of mobilized peripheral blood HPC transplantation has transplanted into shorter duration of cytopenias, enhanced immune reconstitution with a reduction in infectious complications and overall reduced morbidity following transplantation. Individuals may require central venous access or may develop side effects of growth factor, chemotherapy, or anticoagulation used during the apheresis procedure. T lymphocytes, also known as CD3 positive cells, are found in larger concentrations in a mobilized peripheral blood collection, which is associated with a high risk of chronic GVHD. Here, Bensinger and colleagues compare the cellular content of mobilized peripheral blood to bone marrow from related donors per kilogram of recipient body weight. The table shows that peripheral blood grafts contain approximately 3 and 12 times the number of CD34 positive cells and CD3 positive T cells, respectively, than were present in the bone marrow grafts. Most bone marrow donors require general or spinal anesthesia. In bone marrow collections, pain is common during recovery and can be present for the majority of donors for 1 to 2 weeks. Peripheral blood stem cell collection is now the primary source of stem cells for HPC transplantation. The Center for International Blood and Marrow Transplant Research Transplants Activity Report covering 2010 to 2014 revealed a near tenfold difference in peripheral blood as a progenitor cell source versus bone marrow, with the major difference being noted in autologous transplantation. The recovery of adequate HPCs from peripheral blood includes effective mobilization procedures and efficient apheresis techniques. Agents used to mobilize HPCs prior to collection include chemotherapy in patients with malignancy and where cytoreductive treatment is required. During the recovery phase after chemotherapy-induced marrow aplasia, the HPCs are increased 20 to 25-fold. Here, mobilization is enhanced by post-treatment administration of a recombinant cytokine. Other patients and all allogeneic donors are mobilized following cytokine alone. The most commonly used cytokines is recombinant human GCSF or filgrastim. Another form of recombinant GCSF, lenagrastim, is not available in the United States but is used for HPC mobilization in Europe. GM-CSF, sargramostim, is seldom used for mobilization now, but remains available as an alternate option. Over the last decade, a more novel agent, plerixafor or mosable, has been indicated for patients that are poor mobilizers or who have previously failed to mobilize. HPCs reside within the bone marrow because of cytoadhesive interactions between membrane receptors and ligands expressed on microenvironmental stromal cells. Stromal cells produce the chemokine stem cell-derived factor 1 alpha or SDF1 alpha, an important signaling molecule involved in the proliferation, homing, and engraftment of stem cells. It is the loss of attachment to these stromal cells along with the loss of SDF1 alpha activity that favors the release of stem cells into the circulation. GCSF decreases SDF1 alpha gene expression and protein levels while increasing matrix metalloproteases by increasing the number of neutrophils. This can cleave interactions between HPCs and the bone marrow environment. For a given time in their development, stem cells express the chemokine receptor CXCR4, which is responsible for anchoring stem cells to the bone marrow microenvironment and binding to SDF1 alpha. Blockade of this receptor with chemokine antagonist plerixafor increases circulating HPCs. This cartoon depicts an example of a typical cytokine mobilization and collection procedure. GCSF is more commonly given at doses of 10 micrograms per kilogram per day. there is still limited data supporting higher doses. Apheresis is usually initiated at 96 to 120 hours after the start of G-CSF administration. For poor mobilizers or patients with previous mobilization failure, plerixafor can be added 9 to 12 hours before HPC collection. By comparison, hematopoietic recovery and the day of maximal CD34 cell mobilization after myelosuppressive chemotherapy are generally not predictable. Therefore, blood cell count parameters, including peripheral blood CD34 positive cell count, are followed to determine the optimal time to start apheresis. Side effects of G-CSF occur frequently, but they are usually mild, transient, and dependent on dose and schedule. Approximately 40 to 95% of apheresis donors experience bone and musculoskeletal pain, which typically decreases after the G-CSF is discontinued. Fatigue, headache, and nausea are also common side effects. Mild transient splenomegaly occurs after 5 days of G-CSF in most donors and probably contributes towards the mild thrombocytopenia. Rare complications include marked splenomegaly and splenic rupture, severe thrombocytopenia, and severe bleeding. Additional adverse events with plerixafor may include gastrointestinal disorders and injection site reactions. Earlier randomized phase 3 studies demonstrated a higher proportion of multiple myeloma patients reaching a target of 6 times 10 to the 6 CD34 positive cells per kilogram with plerixafor and G-CSF compared to G-CSF mobilized patients alone. The median number of days to reach more than or equal to 6 times 10 to the 6 CD34 positive cells per kilogram was 1 day for the plerixafor group and 4 days for the placebo group. In another phase 3 randomized control trial, a higher percentage of non-Hodgkin's lymphoma patients managed to reach 5 times 10 to the 6 CD34 positive cells per kilogram using plerixafor and G-CSF compared to patients mobilized with G-CSF alone. Cost is a limiting factor for the use of plerixafor, and the reason why many centers use it only in poor mobilizers or as salvage therapy. For collection, there are several apheresis machines currently on the market. Donors are connected to apheresis blood cell separators. First, whole blood is drawn into the apheresis machine to which anticoagulants, citrate, and/or heparin are usually added. Blood is then separated by centrifugation, which uses differences in specific gravity or density to separate the cells. HPCs are found in the mononuclear layer and are removed by collection channels or ports during the entire procedure, either in cycles or continuously, and the remaining blood components are returned to the individual. Each apheresis session lasts approximately 2 to 6 hours, during which 3 to 6 times the individual's total blood volume is processed. Collections can occur on a daily basis until the target CD34 positive cell numbers are achieved. Adverse events related to the apheresis procedure primarily include pain and complications from venous access, hypotension, and hypocalcemia from citrate toxicity. Citrate-related complications include paresthesias, lightheadedness, and nausea. A prospective study of 2,408 NMDP donors showed 51% of donors having evidence of citrate toxicity. Citrate reactions can be managed by simply slowing down the apheresis process or citrate infusion rate. Infusing supplemental calcium has been required in some donors. Severe acute adverse events were uncommon and occur in less than 1% of donors during apheresis collections. You and colleagues have demonstrated a positive correlation for the number of circulating mobilized peripheral blood CD34 positive cells just prior to collection with the final CD34 positive cell content in the collection bag. This correlation is dependent on the collection efficiency or CE of the procedure. CE is a percentage of cells that are removed from the circuit into the collection bag compared to the total number of cells that go through the apheresis circuit. Factors that may influence the CE may include any interruption to the collection, such that multiple machine alarms, venous access or return issues, donor ability to tolerate the procedure, and apheresis technician experience. It is now common to quantify circulating peripheral blood CD34 cells per microliter of blood prior to apheresis as means of determining if a donor has mobilized well enough, and to maximize collections based on these values using predictive formula. Algorithms have been developed and validated. They allow collection centers to determine what they might actually expect to collect on a given day. Here, the predicted CD34 positive cells per liter of processed blood can be calculated using the peripheral blood CD34 positive cell count just prior to apheresis, the recipient's weight, as well as the collection efficiency. With extrapolation, the algorithm can be used to determine the total blood volume that needs to be collected to collect a targeted CD34 positive cell count per kilogram recipient weight. Collection efficiency given as 30% in this example. These algorithms have now become standard practice in many centers worldwide. Their use allows for a reduction in overall apheresis time with increased donor and patient safety, and allows the apheresis center to project expected yields and schedule procedures accordingly. Thank you for joining me on this Pearl of Laboratory Medicine on peripheral blood stem cell collection.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.